Brilliant. Thank you. Sorry for the delay, everybody. I'll try and sort that out for the next time. So I'd like to chat about hepatitis C today. It's one of my special interests because it's such a fascinating virus with a really, really interesting history. And the bonus with hepatitis C is that it's really so exciting for all doctors who treat it. So gratifying because we have got amazing drugs with massive cure rates, which we had no chance of just a very short while ago. So I'd like to start with an unknown case. Well, it's obviously not unknown anymore. And some of you in the infectious diseases department may remember this case. So I'm sorry if you've heard the case before, but it's a really good case because it demonstrates some of the intricacies and difficulties with hepatitis C. So I saw this lady quite a few years ago. She was 89 years old. She was born in Croatia, and she moved to South Africa as a little girl with her older brother, who at the time of me seeing her was 92 years old, and her parents. Her parents had obviously since passed. And she'd had lots of trips back to Croatia to see her family, but basically lived in South Africa for most of her life. She'd never married. She'd never had any children. She'd worked in an office her whole life as a legal secretary, and now she lives in a retirement village. She was in a private room in the frail care because she was really quite a frail granny. She had dementia with a mini mental score at that time of 23, and she was suffering from recurrent falls. Can have the next slide, please. So she'd gone to a hematologist, and you can see how long ago I saw her in August of that year because she had multiple neck and jaw swellings. They weren't painful, but they had been enlarging slowly over the past 4 or 5 months. And the GP had seen her the month before and asked her to go and see the hematologist. Importantly, she had no constitutional symptoms, no B symptoms. So, in other words, she didn't have a fever, she wasn't losing weight, she was still eating well, she wasn't sweating at night, her chest and abdominals, and she didn't really have many complaints. But she did tell the doctor that she was extremely fatigued and also said that she had quite profound Zika, which is dry eyes and a dry mouth. The doctor noticed that she had some nail changes, and then the patient also said that she had this painful rash over her legs, which I'll show you a picture of, but it was basically a hyperpigmented, painful rash over her anterior shins. Next slide, please. Previously, she'd had a seizure 8 years ago, but it was a once-off thing, and the anti-epileptic had subsequently been stopped. She'd had a cholecystectomy 10 years ago. She'd had lots of dental surgery. So she'd had dental implants and she had lots of issues with her teeth. But those were sort of the only medical history and surgery that she'd had. So really quite a healthy lady. She wasn't on any chronic medication. She'd been a smoker for about 40 years, but it stopped in her 70s. She drank alcohol occasionally and denied ever using drugs. She hadn't had any of the sort of usual screening tests for malignancy that we'd asked for in many years. Next slide, please. So this is a picture of the granny, and I think here you can appreciate the what looks like parotidomegaly, swellings on either side of her jaw, kind of preauricular. And then she similarly had some under her jaw in the submandibular area and in the cervical areas. Next slide, please. Here you can see how this mass, which looks maybe parotid, moving down to the anterior cervical triangle, large, what were really firm, hard, a little bit mobile, non-tender, slowly enlarging masses. Next slide, please. These were the nail changes, which we described as onychomycosis. So there's quite a long list of causes for this, where the tip of the nail bed lifts up. But these are what her nails look like on both hands. Next picture, please. And then she had these hyperpigmented areas over her anterior shins that were really very tender when one ran one's hand down and palpated them. They were palpable. She didn't have any pedal edema, and they were mainly over the anterior calf, well, anterior shin. Next slide, please. So on examination of the rest of the systems, her vital signs were all completely normal. She wasn't jaundiced. Her heart and chest were normal. She had no hepatosplenomegaly. Her abdominal examination was normal. She had a chest x-ray, which was completely clear. She also had an abdominal sonar with hepatosplenomegaly confirmed and also no abdominal lymphadenopathy. So all these very peripheral kind of signs. Her bloods, which were done by the hematologist, showed a pretty normal blood count with a normal differential count. Her kidney function was normal. Her liver function test was normal. Thyroid, uric acid, serum protein electrophoresis. She had a massive folate. Her urine was clear with no proteinuria. They did a sort of an autoimmune workup with a negative ENA, and then she was noted to have a positive ANA, which was homogeneous. It was 1 in 320. Her ANCA was negative, her calcium was normal, and her ESR, which the hematologist did, was slightly elevated. Next slide, please. So the next step was for the hematologist to request an FNA. They FNA'd her thyroid because they were worried about some dodgy looking nodules in her thyroid. This didn't really show anything, just some follicular cells. They then also did an FNA of those parotid and submandibular and cervical glands. It showed small mature B cells on the cytology, and the flow was suggestive of a small B cell clonal lymphocyte population. But this was not shown to be a malignant population. The core biopsy of these submandibular lymph nodes showed no atypical or malignant cells, as well as no granulomatous inflammation. So everybody was pretty stumped, like there was very clear clinical signs, definitely something going on, but really no answer after doing quite a thorough workup. The doctor hematologist then went on to do a hepatitis B and C, did an HIV and tested for syphilis, asked the rheumatologist to see the patients, and they did quite an extensive rheumatological workup, repeated the biopsy at another site and asked the dermatologist to see the patients, and everything came back negative except for the hepatitis C, which was very positive. So the hepatitis C antibody was positive. The next step was to do a PCR, which was also positive. They then did a viral load, which came back at 1.94 million. The genotype was genotype 1B, and the diagnosis was made that this patient had chronic hepatitis C and that all these other complaints and signs were most likely extrahepatic manifestations of hepatitis C, and the patient was sent to me. Next slide, please. And so today we're going to talk about this fascinating virus of hepatitis C, which, can you believe, was only diagnosed, or not diagnosed, was first identified in 1989. I was 9 years old when they first identified hepatitis C. So it seemed to be quite a new infection, or maybe not such a new infection, but newly recognized infection. And I think this is one of the viruses where we've had such massive advances in such a short period of time that really makes it a very exciting virus to work with. If you want to know it's a positive stranded RNA virus, I think the only important part is to remember that it's RNA, it's enveloped, it's spherical. It comes from the flaviviridae virus, and it's from the genus Hepacivirus. And the interesting thing about hepatitis C, and what makes it really difficult to come up with a vaccine, for instance, and potentially treatment options, is that the NS5B RNA polymerase enzyme, which helps the virus replicates has got no proofreading ability. And so this results in the generation of viral mutants, which we call quasi-species. So there's millions and millions and millions of different viral quasi-species with mutations as a result of the viral RNA polymerase that doesn't check itself. And so this makes it really difficult for the control of hepatitis C and the vaccination development. The WHO estimates, and this was from last year, that 71 million people globally are infected with this virus. Next slide, please. So in 2020, the Nobel Prize for Physiology and Medicine was awarded to these three people, Harvey Alter, Michael Houghton, and Charles Rice, who'd been working on the identification, diagnosis, and sort of ability to recognize this infection, and they've been working on it for years. And it's called the non-A, non-B hepatitis mystery, because although we only identified it in 1989, in the 1960s and 70s, scientists started observing lots of cases of hepatitis that were neither Hep A nor Hep B, and so they called them NANB, N-A-N-B, non-A, non-B hepatitis, which seemed to be often linked to blood transfusions, but they couldn't work out exactly what it was. In 1989, a team led by Michael Houghton, Harvey Alter was one of the people, as was Charles Rice, and in collaboration with the CDC, identified this causative agent of the NANB hepatitis, which they realized was actually a new virus, and named the hepatitis C virus. So this was a huge breakthrough, as you can understand, in understanding and combating viral hepatitis. And obviously, they were able to use this with molecular PCR testing. And since then, we've realized that it hasn't just stopped at hepatitis C, that there's a hepatitis D and a hepatitis E. And I'm sure that we're going to carry on getting more and more hepatitis. But I think a very well-deserved Nobel Prize for these three gentlemen. Next slide, please. Okay, so this is in picture form what I've just told you now, and it's not really important to know much about what the virus looks like if you're not a virologist, but what is important to know is the structural and non-structural proteins involved in the viral RNA, because these are targets for treatment and potential vaccine development. So like most viruses, the structural proteins are envelope proteins, nucleocapsid protein, and then the non-structural proteins are the RNA polymerase to help the virus replicate, the RNA helicase, and the phosphoprotein. So just remember this strand towards the end here, NS3, NS4A, NS4B, NS5A, and NS5B. These are the important things for the treatment of hepatitis C. Next slide, please. So what about the prevalence of hepatitis C worldwide? This comes from the CDC from 2024, and the last sort of readings which they had was from 2019. And you can see that most of the hepatitis C is in Asia, with interesting hotspots, like in North Africa, in Egypt, in West Africa, in Southeast Asia, and then really much lower prevalence of hepatitis C in the first world, like Australia, North America, and the rest of Europe. Some hepatitis C in South Africa and South America, but really a very interesting look at where the high levels of hepatitis C was or is. Next slide, please. So put that into a bar chart and we see something really interesting. The prevalence of hepatitis C, one of the highest prevalences globally, was in fact in Egypt. In 2014, the health organization that runs the health in Egypt said that 1 in 10 Egyptians aged between the ages of 15 and 60 were infected with hepatitis C, and that hepatitis C was responsible for 40,000 Egyptians dying every year. Now, why was the hepatitis C prevalent so high in Egypt, and what made this different to the rest of the world? And so you're probably starting to think, well, how is hepatitis C transmitted, and is that related to why the hepatitis C is so high in Egypt? So in the first world, hepatitis C infection occurs usually with IV drug use and through the use of products like blood transfusions and other blood products. In Egypt, this was not really an issue. You didn't really have the kinds of IV drug abuse that happened in the rest of the first world, and neither was blood transfusions really a major thing. But what they did think was, could this be ascribed to the government campaign to treat schistosomiasis? So bilharzia is endemic in Egypt, and in the 50s and 60s, there was a massive campaign to try and treat, as a mass campaign, schistosomiasis. And unfortunately, at that time, this was given via an intramuscular injection of praziquantel, not tablets. And unfortunately, this was a multi-use vial, and we suspect and must have been multiple recipients of a single needle. So it wasn't clean needles giving the injection to each person, and probably with those multi-use vials, this was also infected and transmitted between massive amounts of the Egyptian population. However, it's not the only reason to explain this, because we know that this mass treatment campaign stopped about 35 years ago, and yet the prevalence of hepatitis C in Egypt remains pretty high. So there has to be other modes of transmission. And what they worked out was that most people who had hepatitis C had very regular visits to dental clinics. All of them, or not all, but most people who'd had hepatitis C had some history of a surgical operation. About half of them had had a blood transfusion. Thinking about the transmission of hepatitis C, we could never forget the vertical transmission mother to child, as well as intrafamilial hepatitis C, where family members maybe are cleaning up family members' blood or have access to body fluids. And then, of course, the history of schistosomiasis, which about 50% of Egyptians have. So it is multifactorial driving hepatitis C in Egypt. And then similarly, you can see high levels of hepatitis C prevalence in other countries, like think back to the map. So Nigeria was a hotspot in Africa, Pakistan, Russia, Congo, Japan, Brazil, the USA lower, and India. So next slide, please. So what did the Egyptians do about this? There was a massive, really fantastically organized campaign then to try and work on the hepatitis C in Egypt. What did they do? They first of all increased the number of clinics treating this, and look at there, 3 times the number of clinics so that people could access health care. Then they were able to reduce the cost of the treatment by 85%. And I'm sure if you don't know anything or very little about hepatitis C, the one thing which you do know is that hepatitis C treatment is really expensive, and that's been one of the rate limiting factors. So what the Egyptians did was to take over the manufacturing of the DAAs, the direct acting antivirals, and produce it themselves in Egypt. And this led to an 85% reduction in the cost, making it so much more accessible. And the government then paid for, so these patients got free treatment. They accessed local clinics free of charge, and if they needed the hepatitis C medication, they received this treatment free of charge. So by the end of July 2016, all the patients on the waiting list had been treated. I mean, isn't this the most amazing public health response? And by the end of March 2017, over 1 million people had received treatment at state expense. This cost the Egyptians 3 billion Egyptian, I can't remember what the rand, or at least what the currency value is, but whatever Egyptian, 3 billion of it. A hugely successful program to eliminate hepatitis C in Egypt. Next slide, please. So when I saw my lady from Croatia, I was trying to work out if there was anything special about hepatitis C in Croatia that should have been extra high. Because apart from her dental visit, she really had no risk factors. She hadn't had transfusions, she hadn't had a partner, she hadn't had hospitalizations and surgery, etc. So was this potentially the dental work which she'd had, which she said she'd had many operations and procedures on her teeth. So what are the rates of hepatitis C around the rest of Europe? Really, apart from going towards Eastern Europe, not very high rates of hepatitis C in Europe. Next slide, please. And was there any specific reason why in Croatia you would expect to find a higher rate of hepatitis C? Was there another method of transmission like the schistosomiasis in Egypt that could explain this? And really not. So the kind of ways in which you would get hepatitis C in Croatia was similar to everywhere else in the world: infection, drug abuse, hemodialysis, patients who'd received multiple transfusions, prisoners, HIV positive. I mean, the kind of things that we would expect. And I'll show you a chart of how most people get hepatitis C. Next slide, please. So the next thing to think about with hepatitis C was to look at the different genotypes. And we really have 5 genotypes with A's and B's. And depending on which part of the world you're in, one can expect certain types of genotypes. The interesting thing is that in South Africa, we've got 5A, which we really don't see much of anywhere else in the world. In the first world, in Europe and in the US and in Australia, it's generally genotype 1 and genotype 3. 1B going across the rest of Asia, and only South Africa with 5A. Next slide, please. So let's talk about how hepatitis C, the mode of transmission, and what to expect from it. So first of all, the part which makes hepatitis C really difficult is that the incubation period is really very long. It may be as short as 2 weeks if the viremia is at such a high level, but it can be up to 6 months in the infected person. The average is between 6 and 9 weeks. So once you have been exposed to hepatitis C, the next thing we would expect is acute infection, which most people do not recognize, and many are actually asymptomatic. Very few people will develop fulminant hepatitis, so you can see less than 1% get fulminant hepatitis. And between 10 and 50% of people who develop acute hepatitis C will clear this infection spontaneously. So that's the scary part, is that a minimum of half of the people who are infected with hepatitis C will develop chronic infection. And 50% is really a very optimistic number. It's usually around 70 to 80% of people infected who develop chronic hepatitis C. And this is then a very quiet, asymptomatic infection or disease for 25 to 30 years. Nothing to point you in the way of saying, test this guy for hepatitis C. No manifestations until 25 or 30 years have passed, in which case around a third of those people will develop suddenly signs of hepatic cirrhosis and decompensated liver disease. And of the 30% who develop cirrhosis, 3 to 6% per year will get decompensated liver failure, and 1 to 4% of patients will develop hepatocellular carcinoma per year. So this is a really high risk factor for the development of hepatocellular carcinoma. Next slide, please. And this is where the public health burden comes in people who are unrecognized for years, but then present with signs of chronic liver disease, cirrhosis, and liver failure. So again, to show you maybe something a little bit easier to follow, chronic disease develops in 80%, get a chronic hepatitis, 20 to 30% get cirrhosis, and then the risk of carcinoma is very significant each year after that. to get hepatitis C chronic manifestations and complications faster if you're infected before the age of 20, if you have other hepatotoxins, like if you drink a lot of alcohol, or if you have co-infections with other hepatotoxic viruses like Hep B or HIV, your progression to cirrhosis and carcinoma is a lot faster. If you are female, you seem to be slightly more protected. And if you're infected really young, like with a vertical transmission, maybe things also take a little bit slower. Next slide, please. So this is how most people get it. As we said, in the first world, the vast majority of hepatitis C are injection drug users, where people are reusing needles and sharing needles, and then recipients of blood and products or exposure to machines which can be contaminated, like hemodialysis. You can get hepatitis C through sexual contact, so from an infected partner, but this is not a very common way, and it's quite an inefficient way for hepatitis C to transmit. If it's heterosexual sex. In MSM, unfortunately, the risk for hepatitis C transmission is a lot higher. Then, of course, we have to think about healthcare workers getting needle stick injuries and being exposed to blood splashes, etc. Vertical transmission is about 5%. Dental and other medical procedures, so getting injections, getting body piercing, getting tattoos in places where things aren't done correctly with clean needles, like for instance in prison, or a do-it-yourself tattoo, are the other potential transmissions. And then you can get it from an infected organ, although this is thankfully very rare. Next slide, please. So what are the symptoms of hepatitis C and what's going to make us think about it? And this, unfortunately, is the part where there's really no red flags to say test the patient for hep C unless you can think about some risk factors. So more than 80% are asymptomatic during the acute infection and during the following 25 to 30 years, where they're slowly starting to get signs of liver cirrhosis. The most commonest symptom amongst all people with hepatitis C is fatigue. And in hindsight, everybody's got it. But if you ask all of us, are you tired? All of us will say yes. So it's an impossible sign to use with any weight. If you've been infected for less than 20 years, the hepatic manifestations are very mild. So most people will have a normal liver function test and may even have a normal transaminase or a very mild transaminitis. If you've been infected for longer than 20 years, the hepatic manifestations are a lot more common. And this is how people usually present, with signs of chronic liver disease, starting to develop portal hypertension, so developing varices and maybe having an upper GIT bleed, melena, a chronic anemia, making you start looking more. And then obviously as time progresses on, the signs of cirrhosis and liver failure. Now, 3/4 of people with chronic liver disease or with hepatitis C will have extra hepatic manifestations. And so maybe these are the kind of things where one would start thinking about hepatitis C. So arthralgias, 1/5 of patients, up to 1/4 of people will have sore joints, but not really arthritis. And often they get seen by rheumatologists. Paresthesias, so funny pins and needles in hands and feet. Myalgias, non-specific sort of muscle pain. Lots of people are itchy and want to scratch. And then about 10% of people will have sicker, so dry eyes and a dry mouth. Next slide, please. So other extrahepatic manifestations are hematological, where patients can have mixed cryoglobulins. It can affect the bone marrow, so aplastic anemia and thrombocytopenia. You can have non-Hodgkin's B-cell lymphomas. Dermatological, so you get porphyrias, you get lichen planus, you get necrotizing cutaneous vasculitis. And on that patient, which I showed you, we thought that she had a vasculitis over her anterior shins. Kidneys, you always need to look for proteinuria, nephrotic syndrome, and glomerulonephritis. Endocrine things, so antithyroid antibodies, patients may become diabetic. sialadenitis because of the salivary gland involvement. You can have corneal ulcers and uveitis. Vascular things, again, the vasculitis and the polyarteritis nodosa, and was the shin lesions potentially polyarteritis nodosa, and then neuromuscular manifestations, the weakness, the peripheral neuropathies, the arthritis or arthralgia. And I want to put an extra little thing in there, and that is potential seizures. So I've had 2 patients recently, both of them HIV positive, both of them not pure hepatitis C, but both presented with an acute confusional state and decline in their neurological functioning, cognitive ability, and were having ongoing seizures. Both of these patients had high protein in their CSF with no cells and no other positive findings, but a hepatitis C, strongly positive with viral loads around 1.5 to 2 million. Both of the patients were treated for hepatitis C. The one guy is in the middle of his treatment now. The first patient, since the hepatitis C has been treated, she has not had a seizure, and this has been about 3 years now. Her mental state has improved so much that before she was living in care, needed somebody to help from a cognitive activities of daily living point of view, and now this patient is completely functional and able to manage to do things totally independently. So really very, very interesting. And what I wanted to say is when you find patients with risk factors, always check for hepatitis C. Next slide, please. What are the other extra? Okay, we can skip the slide. I think the previous slide told us about that. So what's going to trigger us to test for hepatitis C then, given that people are totally asymptomatic, may have completely normal liver function tests, takes 25 years for them to develop signs, in which case it's already too late because the damage has been done to the liver. So who are we going to test? So this is what the ITSA guidelines recommend for testing and patients for and screening for hepatitis C. So they say everybody should have a test if you are over the age of 18, a once-off test. If you're pregnant, you should have hepatitis C screening with each pregnancy. If you're an IV drug user, you should have hepatitis C testing probably every year. If you are HIV positive, you should have a hepatitis C test. If you are MSM, you should be tested regularly. And in patients with high risk, and on the next slide, I'm going to tell you some of the other risk factors. So what's different to the previous slide is the second one. In the US, they recommend people who use glass crack pipes should be tested. Obviously, anybody who had a mother who was hepatitis C virus positive. We add to the list of risk factors people who are healthcare workers. So if you know you've had a needle stick injury or splash, you should definitely test yourself for hepatitis C. And then every year following that, if you're MSM, not just if you're HIV positive, but if you are going on to PrEP because you are in a high-risk relationship or in a discordant relationship, these patients may get hepatitis C and not necessarily HIV because they're protected from the PrEP. If you are a dialysis patient, you should probably be tested at least once a year. If you receive blood or products before 1992, remember that was around the time when it was first discovered, and so we're then able to start testing blood. If you've got a deranged LFT, and I think that's where we're all really good, is if you've got and transaminitis, we do hip studies on you. If you've had a solid organ donor or you're a recipient of the organ, and then people in prison, if you've ever been incarcerated. So those are the ones to consider doing regular hepatitis C testing on. Next slide, please. So how will you test? The first thing we ask for is a hepatitis C antibody, and this is a screening. If the antibody is negative, we don't detect it, you can stop testing there. You can assume that in the vast majority of HCV antibody negative, these people do not have hepatitis C. If your antibody is positive, remember about 20 or 30% of those people will clear the infection themselves. So the next test is to check the hepatitis RNA. So we do an HCV quantitative test. Is it positive or negative? If it is negative, you do not have current hepatitis C infection. And so this is most likely either a false positive antibody test, where we'll show you what some of the causes of that are, or you are one of the lucky ones, one of the 20 to 30% who cleared this infection by yourself, and no further testing is required unless you're in one of the high-risk groups where you could have ongoing potential for transmission. So if the quantitative test is positive, we'll go on to do, if the qualitative test is positive, we'll go on to do a quantitative test, looking at the viral RNA, the viral load, the genotype, and then move onwards to the rest of the diagnostic stages to figure out where you are in the state of hepatitis C infection. Next slide, please. So what could cause a false positive? Usually the antibody is detectable from around 10 weeks after you've been infected. We use an ELISA usually in South Africa, and there are false positive antibodies. First of all, there's always cross-reactivity with antibody tests, and this could be with other viral antigens or other cross-reacting antibodies. So you'll often see this come up positive in patients who've got lupus or other connective tissue disorders, where they're just making multiple streams of abnormal antibodies. False negative results could happen in the window period, so less than 8 weeks following infection. And then patients who are immunocompromised and who have a poor antibody response. So that could be any kind of immunocompromise, but we think specifically of HIV positive people and people who are transplants where their immune system is being suppressed. Next slide, please. So if you come back now, hepatitis C, RNA, viral load is positive. What else do you need to do? You need to do a genotype. And this in the past used to be really important because this genotype used to tell us what treatments to use, because in the past we had genotype specific treatments. Not anymore. Things have become so much simpler, so it's less important. But it also gives us maybe an idea of which lineage and where this infection was possibly acquired. We do a viral load. We check everybody with hepatitis C for HIV and hepatitis B. We also check them for hepatitis A to make sure that they're immune. And this is to try and vaccinate these people so that you protect them from getting other liver infections. We want to know what their liver function test is. We want to know what their INR is. And this is for staging or Child-Pugh score. We want to know what the alpha-fetoprotein is. And we also sonar their liver, and this is to look for signs of chronic liver disease, portal hypertension, and hepatocellular carcinoma. So it's kind of staging. And then the next thing we do is a fibroscan, which is sort of, in most cases, replace the need for a liver biopsy, which is fabulous. Next slide, please. Okay, so if you're HIV positive, obviously you'll want to start treatments. If you're hepatitis B surface antigen negative and not immune, you want to vaccinate the person for hepatitis B. Similarly, if they are not immune to hepatitis A, we want to vaccinate them for hepatitis A as well. Next slide, please. And then we want to work out our Child-Pugh score based on all the markers that we've just done. Next slide, please. So what is a fibroscan? A fibroscan is a measure of the stiffness of the liver, and it's replaced the need in most cases for a liver biopsy. It's a completely non-invasive device. It's fabulous. It has got almost zero complications versus think about a liver biopsy where you've got to admit somebody, stick a huge needle in their liver. It's very sore. There's lots of complications, some of which are really fatal if the patient has a massive bleed. And the fibroscan is basically just a sonar that tells us the hardness or stiffness of the liver by using transient elastography. So what it does is it's a little box like on the picture. You stick it against the liver, and the sonographer will then do 10 shots, and it checks for the wave velocity that goes through the liver. You do it 10 times, and you take the average to work out 2 kinds of scores. Next slide, please. So it tells us a CAP score, which is a measure of the fat in the liver, and it tells us the fibrosis or E score. So can you see how many different chronic liver disease diagnoses this is useful in? Because it's not just useful in hepatitis C. It can tell us scores for NASH and ASH. It can tell us scores for other infections, hepatitis B, HIV, co-infected with hepatocellular HCV infection, and even in alcohol-related disease. So it will give you an S1, an S2, an S3, depending on the number of dBs per meter. And then the KPAs, or the pressure, will give us an idea of the fibrosis score. Next slide, please. And that means that based on those, one can decide how much fat is in the liver, how much fibrosis in the liver, and then give an idea of where the person is on the way or on the path to fibrosis. The Child-Pugh score, I'm sure you know all of this. Just to remind you, you use the total bili, the serum albumin, the INR, the ascites, the hepatic encephalopathy, work out whether the patient's class A, B, or C, and that gives us a prognosticator for how long their 1-year survival is. Next slide, please. Another score which you want to do in patients with any kind of chronic liver disease is to do a FIB-4 score, and this is another non-invasive measure of hepatic fibrosis. So we're very lucky that in Joburg there is a FibroScan at Donald Gordon, and I'm able to send patients there. I'm not sure, but I think most governments, places are still having to rely on liver biopsies. But in the absence of being able to do a liver biopsy in your institute and not having access to a FibroScan, one can measure the FIB-4 score. So you take the patient's age in years, their AST level, and divide it by their platelet count times by their ALT, half of the ALT, and you work out a score. If it's more than 3.25, this patient has got cirrhosis. And this is just a nice way to non-invasively, if you don't have the support for a biopsy, to work out where they are in their disease. Next slide, please. Okay, so this is all the workup in a patient who's hepatitis C virus positive. The next step is to obviously treat them. So what are the options? So I'm just reminding us about our viral non-structural proteins, which have become the target for the direct-acting antivirals. The DAAs act against the protease inhibitors, which is NS3, the NS5A inhibitors, which, as the name suggests, works on the NS5A, and then the polymerase inhibitors, NS5B. Next slide, please. So, okay, sorry, this slide's in the wrong order, but you'll see on the next slide why. And one more, please, Jeremy. Thank you. So this is the evolution of hepatitis C treatments. In the 1990s, we used interferon alpha, and that had a dismal response for treatment of hepatitis C with cure rates of around 10, if you're really lucky, 20%. In around 1998, they added the antiviral ribavirin to interferon alpha, which doubled the rates. Between 30 and 40% of people were cured. In the 2000s, they pegylated the interferon and added it to ribavirin, and then about half of people could expect to be cured. And then in 2011 came the DAAs, the protease inhibitors, and they were given with the pegylated interferon and the ribavirin, and now we're getting rates of 80% cure. And in 2013 came some really great protease inhibitors and NS5B inhibitors, and huge improvements in the score. So just to remind us about what pegylated interferon does, it conjugates the polyethylene glycol, which is what PEG stands for. So it pegylates and conjugates this interferon, and that extends the half-life. So it means that you increase the antiviral activity, and means you only need to give it to the patient once a week instead of daily. So could you go back 2 slides, please? I want to show you how interferon works. Basically, the interferon alpha induces an antiviral state in the cells. Remember, interferon is part of a cytokine response. So what we're trying to do is improve and give the patient extra cytokines as part of an immune response to fight infection. This means that it inhibits viral replication, and all it does is actually enhance your own antiviral immune response. Next slide, please. Ribavirin is an immune modulator. It's a very non-specific antiviral. It inhibits, in this case, the hepatitis C virus RNA-dependent RNA polymerase and induces, one hopes, the viral mutagenesis. But you know that ribavirin is quite a non-specific antiviral. And then I think we can go 2 slides on, please. Great. So the game changers came in 2014 with Harvoni, which was the combination of sofosbuvir and ledipasvir, and in 2015, where the other spheres came, bitosphere, paritaprevir, disubavir, and declatisvir. Next slide, please. So with these DAAs, from 2015 onwards, hepatitis C becomes the first very highly curable chronic viral infection. Next slide, please. So this is what happened in 2015. And I want to just show you how difficult it was in the beginning, because the genotype meant you had to choose different kinds of DAAs. So you had to know what the genotype was to choose the correct direct-acting antiviral. And depending on that, you were able to give an interferon-free regimen, but you had really quite complicated antivirals to do. Next slide, please. Versus, okay, again, this really complicated depending on genotype, and that also decided how long you were going to give your direct-acting antivirals, which could be up to 24 weeks. Next slide, please. So 2018, we got Epclusa, sofosbuvir, velpatasvir, and the exciting part about Epclusa was that it was pangenomic. So for the first time, we had a DAA that worked for almost all the genotypes almost equally, and one didn't really need to know exactly what the genotype was. And I'm going to focus now the rest of the talk, which we're going to be an extra 5 minutes. I'm sorry that I'm going over. It's because I started late with my drama in the beginning. I'm sorry. But I'm going to speak about Epclusa now when I talk about the DAAs. And this is specifically because Epclusa is the only DAA that is registered in South Africa for treatment. Next slide, please. So what do we give? For any genotype, we give Epclusa 12 weeks in patients without cirrhosis who are treatment naive and or treatment experienced with compensated cirrhosis or no cirrhosis. And their recommendation is to add ribavirin on to that in patients with decompensated cirrhosis. Next slide, please. The ITSA guidelines, again, give Epclusa for a duration of 12 weeks or glyceprevir, pirintasvir for 8 weeks, which is fabulous. This is new, but we don't have access to that. Next slide, please. And so there are simplified treatment algorithms which can be viewed on the ITSA website, as well as the American Associated for Liver Disease. And again, any genotype, we give Epclusa for a duration of 12 weeks. Next slide, please. So what do we need to consider before we give patients this treatment? We need to know the hepatitis B status, because the DAAs do have a risk of hep B reactivation if these patients are positive. Also remember that these are inducers of the cytokine enzymes, and so if the patients are on TB treatment, anti-epileptics, warfarin, etc., it can cause interruptions and lower levels of the DAAs. Amiodarone, you can get symptomatic bradycardia if it's co-administered. Next slide, please. Other drug interactions, it's not ideal in patients who are on tenofovir. So the DAA's Epclusa specifically increases the level of tenofovir. So you really need to monitor patients' UNE. You can give it, just need to monitor the UNE. And if you can change them to TAF for the duration of the treatment, that would be ideal. You cannot use it with the NRTIs, efavirenz, etravirenz, and nevirapine. So if the patients are still on one of these old regimens, it would be better to change them to dolutegravir. Diabetes, depending on which drug they're on, you need to monitor very carefully for hypoglycemia. If they're on warfarin, monitor their INR, check their anti-epileptic drug levels, check the anti-TB drugs if they've got co-infection, and obviously the statins. Next slide, please. The adverse effects in trial, very few people experience adverse effects. 0.2% permanently discontinued the treatment of the DAA. So you can see the vast majority of people felt nothing. Of those who got side effects, 80% were mild, and the mild effects that they got were headaches, fatigue, nausea, asthenia, they couldn't sleep, asymptomatic lipase elevation, and asymptomatic CK elevation. Unfortunately, we can't tell you anything about using these drugs in pregnancy or breastfeeding yet. And importantly, you don't need to adjust the dose in renal or liver impairment. Next slide, please. So I want to show you a couple of slides, and I just want you to look at the first sort of result, which is the sustained virological response at 12 weeks of Epclusa in genotype 1A, 1B, 2, 4, 5, 6, and look at that response between 98 and 100% sustained virological response. That means when you do your 12-week hepatitis C viral load, it is undetectable. Next slide, please. Again, in patients with genotype 2, 99%, and they compared Epclusa 12 weeks, 99% sustained virological response, compared to sofosbuvir with ribavirin at 12 weeks, 94% response. So huge improvements with Epclusa, with none of the side effects that come with ribavirin, which is quite a nasty drug. Next slide, please. And then looking, okay, genotype 3, similar. Next slide, please. And this was in patients who are co-infected with HIV. So this is of importance to us here. You can see that the response is slightly less than those excellent responses in patients who are not HIV positive. So you're getting a sustained virological response of 92 to 95%. And genotype 3 is the tricky genotype with this drug, where the response is always slightly less. But I think you'll agree that at over 90% sustained virological response is still worth it. Next slide, please. Even in patients with decompensated liver disease, so who are already starting to go into liver failure, 94 to 100% sustained virological response depending on their genotype. Next slide, please. So what do you do once you've given the patients this drug? So first of all, unfortunately, it remains very expensive. It's around 8 to 9,000 Rand a month. So the treatments cost about 25 to 30,000 Rand for the 12 weeks. We do a viral load at 12 weeks, and we expect a viral load that's undetectable, and then we call it a sustained virological response. If the patient gets a sustained virological response at 12 weeks and they have no signs of cirrhosis, so their child's pew, their FibroScan, etc., are normal, then that's it. There is no liver-related follow-up required. And the relapse rates are so low that it is not recommended that you need to repeat the hepatitis C viral load to see if they've relapsed, unless you're worried about reinfection. So I think this is the take home. If you've treated somebody for hepatitis C, they need to understand that they won't relapse, but they can get reinfected. And then one goes back and thinks about the risk factor list that we just discussed just now to see who needs yearly monitoring of hepatitis C from a new infection point of view. Next slide, please. So what are the things that we can do to try and prevent hepatitis C? Because of the lack of proofreading of that RNA polymerase, unfortunately, there's still no vaccine. There's also no immunoglobulin which can be given if patients have been exposed. And so at the moment, there's really no prevention in people who have been exposed. So what we would do is screen people, like healthcare workers, for instance, when they know that they've had an exposure, somebody who potentially has had been on dialysis or transfusion. We want to screen these people and make a diagnosis early so that as soon as we get a positive hepatitis C, we're able to initiate treatment early and clear them from infection so that they remain a Child-Pugh A, a FIB4 score of super low, and have no signs of cirrhosis. And I think that's my last slide. Yes, thank you very much. Thank you for your patience with me in the beginning and for going slightly over time. So thanks, everybody, for your attention.
Thanks, Kim. Someone quoted us about a testing algorithm. Okay, I'll email them separately. So we don't have, unfortunately, time for questions, but just to say thank you very much, because I think this is an increasingly important issue in the sense that we have so many IV drug users exploding with intravenous drug use really in the last decade that these numbers have shot up in the state sector and in private, and without much of a plan, from Department of Health. So I really think that this is going to become a massive issue in the next few years, which is really sad because it's so preventable, as eventually Egypt showed, which is, as you say, really incredible public health intervention on their part. But what I mean, maybe just in sort of 30 seconds, what do you think is the key pitfalls in terms of treatment that you've seen, and like things to not forget about?
So I think the most important is that we need to screen and find these patients. So the antibody test is not a lot of money. So always try and remember the risk factors for Hep C and screen and test these people. And I've added it to my list of those weird infections where it could present like almost anything. So add it to the list of people with syphilis, which can present in a multi-system odd sort of way. And the great mimicker list, in other words. And then I think what's really going to be a game changer is if we can get the cost of these drugs down, because 12 weeks, you're cured, almost zero side effects. It's fabulous, but it costs a fortune still, although it's been reduced in price dramatically.
And then this is a question about the cost of the FibroScan. I don't know if you happen to know offhand, I guess, for the patient or the machine overall, presumably pretty.
Unfortunately, it is quite expensive. It's more expensive than a sonar, but it's less expensive than a liver biopsy and all the potential drama that goes along with that. But the availability of a FibroScan in South Africa is still not what it should be. There's very few FibroScans. And so those people are trying to pay off their FibroScan, the ones who have it. So it's a couple of $1,000. But I think, sure, to avoid having a liver biopsy, I would save the money to go for that.
Yes. And then Paul was asking about what happened to your patient, because so that the case you started with.
Yes. So, should have put in a slide about that. So her nephew actually paid for the treatment. She had 3 months of treatment. She had a sustained virological response. I saw her about 2 months after that. All the swellings had kind of started getting smaller in size. The rash over her legs had disappeared completely. And unfortunately, I never saw her again after that. And I think, she was 89. She was, I think, over 90 when she was treated and cured. And I think she may have died. And that's why I didn't see her again.
Awesome. Okay, so we're going to leave it there just in the interest of time. But thank you so much, Kim. And I see a question just come through from Tom in the chat. So if you're able to hang around, perhaps you can just type a reply to him in the chat if you have time. And thank you again very much. And nice overview. Awesome.